Yeah, that's a great question. So it'll really, like you mentioned, depend on what treatment you and your doctor select. So the BTK inhibitors are really taken either until there's a side effect that you have to stop taking it, or they stop working and you move on to another treatment. So that's really what we call a continuous treatment. But there's, another treatment called venetoclax. And if this is used for the initial treatment, it's combined with, this is a pill combined with an IV infusion called obinutuzumab. And for example, this treatment is given for approximately 1 year, is what we call time limited or fixed duration treatment. And then, historically, patients received what we call fixed duration treatment, or a time limited treatment with the chemoimmunotherapy, something like you might have heard of bendamustine rituximab or FCR, fludarabine cyclophosphamide rituximab. We don't really use these very much anymore. But those were kind of fixed duration. So like you mentioned, some patients will have that time where they come up towards the end of treatment. We're still, for the chemoimmunotherapy, which we're not using as much anymore, there were, potential for long-term side effects, including one with the FCR regimen that we see as something, actually a secondary MDS or AML could emerge in a very, very small number of patients over time. And so, blood counts were monitored over time. With venetoclax and obinutuzumab fixed duration treatment, we're still learning. It is a newer regimen, so we have 5 years of follow-up from the initial treatment now from clinical trials, but we're still learning, what it'll be like 10 to 15 years down the line. And so as that data comes out from the initial clinical trials, we'll have a better idea. But one thing about CLL is that, unfortunately in 2023, it's still not a curable disease. It's very, very well managed, and patients can live alongside the diagnosis for decades. But even when the treatment ends, if you're doing a fixed duration treatment, it's important to continue following with your oncologist, because many patients, if they're, in a remission, still need, to be followed, because there is a chance of the CLL, coming back and really needing treatment again. And so that relationship doesn't totally end when the treatment ends. Education programs like HealthTree are excellent to kind of find out more about the CLL, what it's like as a disease, because it is very different from other cancers. The other thing that I think is really important with CLL, this is a cancer of the immune system, and so even if we're not starting treatment against the CLL, there's other preventative measures that we can take. Patients with CLL are at a higher risk of infection because the B lymphocytes are the cells that are dysregulated in CLL. And these are cells of your immune system. We also know that other cells of the immune system not involved with the CLL, something called T cells, are impacted in patients with CLL. And so while live vaccines patients should not get with CLL, there's a host of other vaccines I do recommend to patients. A flu vaccine every year, the COVID-19 vaccine series, and then pneumonia vaccine series and Shingrix vaccine series. And then just staying up to date on other cancer screenings. So we do see a higher risk of other cancers, including skin cancers. I have patients go to the dermatologist just for a skin check once a year, because a lot of times with the screening, things can be caught very, very early, and not be removed, not become a problem. Same thing with things like mammogram, colonoscopy, pap smear, prostate cancer screening. So all those other things, we are actively doing, even though, you might not need treatment for the CLL itself.